Well, it's the AV's fault then. How about now? Everybody good? Everybody here? Yeah. All right, perfect. Well, thank you very much. We're going to get rolling. I wanted to wait a couple minutes just to let everybody kind of roll in here. But thank you again for coming this morning. We're very excited to have everybody. We haven't done one of these in quite some time, so it's exciting to get out. Hopefully everybody grabs a lunch. Please either get a lunch now, feel free to eat throughout the talk, or grab a lunch on your way out. It's probably the most exciting reason to be here. Second most exciting reason is to learn about robotic-assisted joint replacement. So that's what I'm here for today. I want to say thank you to York Hospital for co-sponsoring the event. Very happy with everybody and how much they're helping us get this business going. So let's get rolling here. So this is me. My name is Mike Morwood. I did my residency training at Duke University, North Carolina. And then I went and did a trauma fellowship. It was the first fellowship subspecialty training I did. And so I run the trauma room at Portsmouth Hospital, the level 2 trauma center. So that's part of my job. And the other part of my job, I then went and did a hip and knee replacement fellowship in Salt Lake City with Aaron Hoffman. So that's what I do on my elective practice, where I do elective hip and knee replacements. So one of the exciting things, really trying to bring that kind of next level fellowship level training and expertise to this area. And it's been fun. I've been here now, almost 4 or 5 years. So it's kind of flying by. I'm getting older every day, I'll tell you, but it's been a lot of fun. So I want to, again, say thank you for coming. It's exciting to be here. York Public Library has been very gracious, very beneficial to us to bring the talk here. We thought, what a better place for a bunch of folks who potentially have hip and knee pain than the basement where you got to walk down 20 stairs. So thank you, everybody, for coming on in for that. So we'll go through a couple different things. This is a very light, casual talk. I mean, really, I found that the number one thing most people want when they come to these is to ask questions, because everybody usually comes with kind of some pre-existing either questions or maybe some information that they're wanting to get. So if at any time you have questions, please feel free to raise your hand. We'll jump in. But kind of the topics we're going to go, we want to talk first about joint pain. Just what is joint pain, how to describe it, what are some of the experiences folks have, and then the treatment options, and we're really going to dive into that joint replacement surgery. Mako robot, which we've had here at York Hospital now for, Tyler, almost a decade? Right, close to 10 years. We're I think it's actually, I'm if not the only fellowship trained joint surgeon in Maine to be doing robotic assisted hips. So it's a great place, here in York County, York Hospital. We've had some good success. And then again, that Q&A at the end, really, dive into any questions that anybody has. So I'd like to start off with a case presentation. So some of these are very typical for what we hear, for what patients come in and talk to us about. 59-year-old, complaining of some left knee pain. She's had it for many years. She says it's a grinding type of pain. I don't know if that's familiar to anybody else. We're starting to wake her up at night, so she said, look, enough is enough. I've got to go take a look. Can no longer walk around the block without pain. So these are some of the very common things. That's why we're using this one as a case presentation. Here's her knee x-ray. And we're going to go through what the findings are here, but right away you can see there's something wrong here. How that doesn't look like this knee. There's just no space between the bones. Cartilage is all gone. And the tibia is actually shifting. All the ligaments are getting stretched out. So that's what arthritis of the knee looks like. Okay. This is what it looks like from the side. This is such bad arthritis, it's actually digging a pocket into the tibia. So this, again, terrible tibial pain, terrible tibial wear. And underneath the kneecap, you can see all these bone spurs. These are all just big bone spurs. Terrible arthritis of the knee. Mako robotic assisted total knee replacement, straight leg again. She's walking pain-free for the first time in years. So that's a great presentation of a patient, very typical for kind of what I see in my clinic. This is what it looks like from the side. And again, we're going to go through all the specifics on this as to what a knee replacement actually entails, because there's a little bit of kind of some misnomers in terms of what a knee replacement actually is. So your joints are involved in every activity that you do, right? Whether it's walk around the block or walking down the grand staircase to this talk. It really is. Everything that you do rely on those joints moving. And a disease or injured hip or knee can significantly limit your ability to do those activities. One of the most common causes of disability in America today is hip and knee arthritis. So it's a huge burden. It's a huge problem. Some common causes of joint pain, a lot of these are kind of familiar to people, but rheumatoid arthritis, we used to see that a lot more. Now with the advent of some of the newer biologic medicines, that's sort of thankfully going away as much in terms of the joint destruction that it causes, but we still see it from time to time. Probably the most common one that we see is this osteoarthritis. This is also known as the wear and tear arthritis. This is years and years of activities on the joints, whether maybe you had an injury as a child, and then it's just been this year after year of grinding away. But that's the number one cause, that osteoarthritis. And then another thing that I see in my practice, being a trauma surgeon as well, is post-traumatic arthritis. So we know if you've either had a hip fracture, a knee fracture, something that causes damage to the joint itself, very high risk for developing arthritic change down the road. There's always the non-surgical options, and we try every one of these beforehand. I like to talk like a ladder, right? You got to start at the bottom before you work way up to the top. So we want to try the non-operative walking aids, whether it's a cane, a walker, a crutch, things like that. Heat, cold can also be helpful. Pain relief adjunct. Physical therapy is very good. So physical therapy a lot of times helps strengthen the muscles around the joint. So even if you have a damaged or a dysfunctional joint, the muscles around can actually provide some protection. So we like to get folks into some physical therapy. Even if you're having a knee replacement or a hip replacement, we like doing a little bit of that prehabilitation, we'd like to call it. And then the over-the-counter, the anti-inflammatories, these are the mainstay. That's your ibuprofen, Motrin, Aleve, Advil, Tylenol. Great medicines for osteoarthritis, for this wear and tear arthritis. Very good for pain relief. Number one thing I hear, am I ready? Is it time? Am I a good candidate, right? I always like to kind of throw it back and say, you got to answer these questions, and if you answer yes to any of these questions, you probably know it's time. Is joint pain affecting your ability to get a good night's sleep? Like our case presentation, the first lady of the day, she said, when I started waking up at midnight every night, 2 a.m., can't get comfortable, putting pillows between my legs, just not working out for me anymore, that's when I knew the time was right. How about joint pain keeping you from doing the things you love to do? Hey, I used to play 18 holes of golf. Now I'm barely karting around 9. My backswing has taken off. I can't get down to the ground and play with my kids and grandkids. These are all things that we hear, and it can be a reason really to consider joint replacement. Are you becoming less active? And is joint pain affecting your ability to walk up and down stairs, get in and out of a low chair or a car? These are these daily activities, these activities of life, that joint pain can affect and significantly disable. So we're going to start with total hip. All right, we'll go from total hip to total knee, but we'll start with total hip, and we'll do a little bit of framework as to what the robotic assistance does for us as well. So hip anatomy, all right, we're talking a ball and a socket. Very basic, is what orthopedic surgeons like, basic analogy, ball and socket. Normal hip, arthritic hip. It's not projecting very well here, but basically cartilage loss, narrowed joint space, arthritic, irritated, red, inflamed looking tissues. That's what arthritic hips are. And this is what it looks like on an x-ray, okay? Normal hip here on the left-hand side of the screen, you've got a good space between the ball and the socket, no big bone spurs or anything like that. This is an arthritic hip. Completely, square peg and round hole. No space left between the bones. Lots of white sclerosis. That's bone that's become marble-like in response to all the new stress. Some cystic change here you can see up there in the S7. Those are bone cysts in the femoral head as well. So this is a worn-out hip. That's what arthritis of the hip looks like. And here's how our total hip replacement actually works. If I can get this to play. I don't think there's any sound to this, but there we go. So basically, when you strip everything down, removing all the extra anatomy just to see what's going on. A hip replacement, you remove that damaged ball, you put a pin or a new socket kind of up in the shell. There's a plastic liner that everything goes in between. Pin goes down the leg. New ceramic ball goes on the head, and the hip is reduced. So you keep your bone, your ligaments, your muscles, everything is yours still. It's a new ball and socket. That's it. So all of the surrounding musculature, it's all untouched. Okay? So hip replacement, how it works, right? And you're removing the arthritic bone and damaged cartilage, and then we have that new system there. Pin down the leg, new ball, plastic liner. That's what that looks like from A to B. And this is what a hip replacement looks like on an x-ray. So whereas before we saw that damaged hip, bone against bone, no space left, this is the new ball, new socket, pin down the leg. Again, all the muscles and ligaments and everything that's around the hip joint itself is all yours still. So it's just a replacement of that ball and socket. And then the robotic assistance. So here's the kind of the meat and potatoes of the talk, all right? A lot of people ask me, hey, you're doing robotic, are you even in the room? I wish, right? We're waiting for that day. No. But honestly, it's better described as robotic assistance. So we'll show you a little video of kind of how things work. But this is the actual robot itself. This is all that's there. This is the feature, the key feature. This whole machine is here just for this part. What it does is it does everything. I'm pulling the trigger, doing the moves, moving everything out. It's just keeping you in this little tractor beam. We put together a plan preoperatively, and I'll show you how that's done. And then this robotic arm only lets me do exactly what I want, down to a 0.5 millimeter of accuracy. So it's incredibly precise and anatomic in how we do things. So we're gonna describe all this stuff with another case presentation. Okay? 55-year-old male comes in and says, I have terrible right hip and groin pain. His number one complaint is he can't move his foot from the pedal of the gas to the brake when he's driving. So every time he goes and sees the stop sign, he's like, maybe I'll roll through there a little bit, right? Because it's just hurting too much to move my leg. So that's what brings him into the clinic. And now here we see, on the left side, he's got some space there between the ball and the socket. On the right side, complete bone on bone. Everybody see, that's what hip arthritis looks like. He's got big bone spurs there. There's that white sclerosis we're talking about that he doesn't have on that other side. So this is right hip arthritis, okay? 3 parts to the robotic assistance. The first part actually begins before you even get into the operating room. There's a CT scan. This CT scan is a personalized scan that you get that we're then able to develop a 3-dimensional anatomy model from. And so from that scan, I'm able to now see your bone in 3-dimensional space. Then I can go in and I can customize and put exactly what implant is going to fit your bone and your socket the best. And then we're able to plan that even before we get in the operating room. So all of these slides, which I'm about to show, happen before we're even there. That's why we know exactly the plan, the components, the fit, the placement, all of that is done to within a 0.5 millimeter. So that's really the meat and potatoes of the robotic assistance. It's not even in the operating room, it's almost beforehand. So that's what this 3-dimensional model looks like. Now I have these images where I'm able to put this cup, this green cup, exactly where I want it to go. I don't want to be out here, I don't want to be too deep, too far back, too far forward. It's matching that patient's native anatomy perfectly. And here again, here's that 3-dimensional CT scan. I can see where my cup is in space. And over here, I'm able to see my dimensions. I know the inclination, meaning kind of where that cup is looking and lining up. What's called version, that's where it's looking in the other plane. I can see exactly where his hip center is going to be. And then from there, I can actually put the stem on and reduce the hip. And again, this is pre-surgery. And I say, all right, perfect. Now our leg lengths are perfectly equal. Only 3 millimeters of increase, what's called offset. But 3 millimeters, we're talking like that, and leg lengths are equal. And I'm able to dial this all in before we even get in the operating room. So I know the size, he's a 52 cup. I know where that stem's going to be placed. I know what size stem. It's all about implant placement, accuracy, precision. And that's what the robotic technology allows us to do. There's no more guesswork. I'm not sitting there kind of looking at an old x-ray thinking, could be a 4, could be a 5, let's see. I know what I'm going to do. And this is actually in the operating room what this looks like. So here's that robotic arm. Everything is draped in plastic because it's sterile. So this is me pulling the trigger. I'm looking up at that computer screen showing exactly, again, where we want that to be. It's only letting me go where I want it to go. It's not letting me deviate. And there's that robotic arm. So this is me doing a hip replacement surgery. See, I'm actually in the room, so this is real proof, right? I'm there. I didn't leave. All right, so those are the part 1, CT scan. Part 2, implant placement. Now here's the third part to the robotic technology. This is intraoperative balancing technique. So after I get my hips reduced, I get real-time measurements. All right, so now we're actually 2 millimeters longer. Maybe I didn't sit that stem 2 millimeters. Didn't sit that stem 2 millimeters, okay? So what I can do is I can upsize the head a little bit. I can downsize the head a little bit. Whereas, you know, we may think, oh, 2 millimeters is only about that much. Why not make it 0? Why not make it perfect? There's no reason to have any sort of, you know, terrible errors anymore because of this technology. We're allowed to have implant placement with accuracy. Yes?
Now, you said it's keeping you from going in the wrong places when you're placing it.
Yeah.
Is it physically doing this, or is it keeping, or is it?
Yeah, it's a good question. It's haptic guidance. So it literally will not let the arm itself move to a different direction. Yeah. So when I was seeing all that green on the screen, you can kind of see that there. It only lets me remove that green. If I tried to crank it one way or the other, it would just go back. It would just stop. Would not let me. It's like a virtual tractor beam. It's $1 million robot. It's a little stronger than I am. All right, and so here's what he ends up with. Okay, so if you go and look at, I don't know if I can cross him. This is what we want it to look like, and he ends up with the exact same implant, X-ray, leg length, offset. Everything was dialed in. So it's, to me, a very good, nice way of performing a hip replacement surgery, because the accuracy, the implant placement, the technique, it's just, there's no guesswork anymore. And we used to, you know, in residency and training and things of that nature, we'd say, well, you know, they'll get used to a little off, or their back will, we don't need to do that anymore. We're able to kind of just dial this stuff in. So that's hip replacement with robotic assistance.
Is the recovery the same if you don't have a double?
Yeah, that's a multifaceted question for sure. I think some of it will include a little bit of what I'm about to talk about, which is actually approach to hip replacement surgery. A lot of the robotic assistance allows us to use less exposure, because beforehand I need to see the entirety of either your hip or knee, because I need to visually see where I'm going, because I could break by accident. Whereas now, I literally cannot go past this if I wanted to. So I don't necessarily need to see way over there. So there's a lot of studies that have looked at that and have said, yeah, there's decreased narcotic usage, there's lower, you know, surgical times, there's lower hospital admission, things of that nature. But a lot of it, I think, is because of the exposure. So then another thing that I do, which is a little bit maybe different or potentially kind of newer, is this direct anterior approach. You may have heard about that in hip replacement surgery. So multiple different ways to get down to the hip. Right? There's the kind of posterior lateral, which is the biggest exposure, which is a lot of times I'll use that for revision surgeries, things that you need to see a lot from. Typical direct anterior approach for me is about a little credit card incision like that in the front of the hip. Move the muscles around, do our work, muscles come right back. There's no muscle cut, there's no muscle tears, anything like that. Just, it's a nice approach, a nice window into the hip joint.
Can you have an MRI after a total hip replacement?
Yes.
The metal into the femur?
Yep.
Is it metal?
It is metal, yeah. It's a titanium stem and a titanium hip socket. It's all MRI compatible. What's that?
Okay.
Yeah. So yeah, so this approach has been very nice. I mean, I think a lot of people will tell you it is definitely a quicker recovery. So most of the time, first 2 to 6 weeks, it's you're back doing a lot of things that historically maybe you weren't doing. You know, full disclosure, I do hip replacement from the front, from the back, from the side. Do anything that's necessary for the particular patient, particular circumstance. And I will tell you that first 6 weeks is usually a lot faster for direct anterior approach history. In the end, a very well done posterior hip will do just as well as a very done anterior hip. It's definitely that first 6 to 8 weeks though is a quicker go at it. Is it?
I'm not a plant coach, but I had my hip done, or right hip done, over in New Hampshire by the same group. 2 years ago, this coming August, I was driving 11 days after the operation with pain level of 1 to 2. So
Not a plant.
It works. And I wish I had done it 5 years earlier. Just so you know.
You did it. Don't wait.
Don't wait.
Sign up sheets will be out front. Good. All right. So here's just a little diagram, kind of what we're talking about, direct anterior approach versus a posterior lateral approach. Again, there's no knock on any particular thing. There's plenty of great surgeons. I trained under surgeons who did posterior approach. Phenomenal. If you do a good job, hip replacement is a hip replacement. You'll do great. But I think everybody would tell you, and it would agree that anterior approach is certainly, it's a quicker recovery. All right. Another huge question that I get all the time. Hey doc, my hip, terrible. I'm hurting so bad. I can barely move. You know, this staircase to get down to your talk was miserable. Am I too old for surgery? Everybody says I'm too old. It's over, it's done, nothing to do, right? Completely disagree. That's the first thing I'm going to tell you is I completely disagree. This is a study that came out when I was down at Duke University talking about hip replacement in seniors. This is a non-surgical group. These are the rheumatologists who did this study, so there's no bias, there's no surgical bias. They found that seniors with arthritis were twice as likely to show improvements in functioning and ability to care for themselves, and no age limit was seen on the benefit increase. All right, so when anybody talks about age, you know, sort of thing, it's always a conversation to have. I'm not saying, you know, it's a great idea, it's a terrible idea. It's everybody's an individual person, has their own medical problems, has their own activity levels, their own expectations. But what I want to convey is don't let it be a non-starter. We should have the conversation to say, here's your risk, here's your benefit, here's what I think we can do, here's what I think could potentially happen. And then, you know, it's a conversation to have where we have that discussion. We say, you know, what are you looking to get out of it? But never have that sort of, nope, non-starter, not going to happen, can't do it, won't do it. I think the oldest person I've ever operated on was 106. It was a trauma, had to be done, right? I'm not signing up 106-year-old hip replacements, but certainly, you know, it just because of an age, right? That she made it. Didn't look a day over 100. Oh, she did. Yeah, she did well. She did really well. So it's just like I said, it's just a conversation to have. So it's a risk-benefit analysis for sure. But this was a very good study that really kind of opened our eyes to some newer data that said, hey, you know, this could be a significant benefit for folks. So that's hip. Okay, we're going to go on to knee. Anybody else has hip questions? Yeah.
So once you're operating on the hip and do you check all the measurements before you close them up? You know what I'm saying? Before you close up the deal to make sure that, but then, okay, let's say that that's all right. Do you have any shifting in the human body after you get up and you know, does shifting happen? And can you have a leg that's longer or shorter than the other? I mean,
yeah, for sure. So a lot of what we do is what's called a press fit. You take that pin, you wedge it in the femur, and you try to knock that thing as hard as you can without breaking something.
yeah.
The idea is that it wedges itself in, and then your body grows in over time. Every once in a while, you wedge it, and it will the bone will kind of relax over the next 6 to 12 months, and maybe it edges down. It's called subsidence. We don't like seeing that. Every once in a while, it happens. Usually millimeters. But yeah, I mean, even in the best case scenario, sometimes things can be off slightly. About 33% of the human population has a leg length discrepancy at baseline. That was borne out. There was a Canadian military study. They looked at military recruits for 10 or 15 years and found that number, 33%. Nobody knows it. It's just the way things happen and your body sort of accustoms and deadjusts. So most of the time, very well tolerated. And again, you know, nowadays we're talking millimeters. So a centimeter is that, and we're talking maybe 3-4 millimeters. It's imperceptible. But yeah, things do shift every once in a while.
Can you overdo it post-op?
Yeah. Yeah, 100%.
Don't push it.
My line is always, don't overdo it, but don't underdo it. You know, the only reason I tell people not to overdo it is because it may hurt, may, you know, slow their recovery a little bit. It's not necessarily that you're damaging implants, you're damaging anything like that. You just want to find that sweet spot. You know, some people come in at 2 weeks and they're on a walker. Some people come in at 2 weeks and they're carrying their walker like King Kong. Everybody's a little different. It doesn't mean anything is right or wrong. It's just everybody has that, you know, trying to follow that bell curve.
Does the fact that I'm 90, is my recovery longer?
I would say everybody's a little different. You know, everybody's a little different.
It wouldn't be the same as when I'd be 50.
Potentially not, but I'd say I've seen some 50-year-olds who could have some circles run around them by folks that are 90. You know, So I think everybody's a little different in terms
Because
of
I
how
had
they
the
do it.
knee done by you and the recovery was okay.
It goes like that.
Yeah, this is premature when you talked about hip, you talked about knees.
Yep.
What about other joints in the body? They
Shoulder.
This kind of shoulder,
Yeah.
ankles, wrists.
Yeah, there's a huge push in technology in the orthopedic space. The Mako, specifically Mako robot, is hip and knee, but they're working on shoulder. There's certainly other applications around the body in terms of shoulder and knee and hip and all that sort of thing. But there's a huge push towards it because what we're seeing is it used to be 20, 25 years ago, it was, do you have stainless steel or titanium? Locking screws came out, locking technology, and huge leaps. Nowadays, implants are all great. Everybody can come up with a very good hip, a very good knee, a very good plate for a fracture. It's now shifting more towards instrumentation, placement, accuracy. Whereas before, 30 years ago, if you got a hip done for rheumatoid arthritis, you were just happy it wasn't put backwards. You were just happy. Right? But nowadays, I want you out golfing again. I want you playing pickleball, tennis. You can't tolerate 2.5 centimeters of leg length discrepancy anymore. And so the hip replacement itself is not going to wear out. It's how you do it, what your exposure is, what your implants are, and that sort of thing.
Two questions. In inserting the replacement ball, you're going to have to shift that bone somewhat. So what happens to the ligaments and muscles? Are they stretched, and how do you handle that? And the other question is, what's the expected longevity lifespan of these replacement parts?
Yeah. So to the first point, don't watch any YouTube videos on joint replacement prior to having a joint replacement. You're going to see your leg put in a position that you would never figure that's impossible. The human body can withstand some things. And so yeah, things get a little stretched, and you can have some aches and pains here and there after that are not even from a hip or a knee. You may say, my hip hurts, but I had my knee done. My knee hurts, but my hip was done. My shoulder hurts because of how I was positioned on the table for it. So there's some things that happen. It's usually inconsequential. It usually gets better. And then the second part, so in a typical hip replacement, the metal, is never going to wear out. What wears out is the polyethylene, the liner between the ball and the socket. Prior to the year 2000, we had about 10 to 15 years of shelf life on those. So we wanted to wait as long as you could because you're going to have a revision very soon. Now, after 2000, we switched to what's called highly cross-linked polyethylene, 30, 35, and plus years of wear. Yeah. So the paradigm is shifting a lot in terms of younger and younger people. Yeah.
How much of a factor is osteoporosis or osteopenia with any kind of joint replacement?
Yeah, it is a factor. When you're wood splitting a stem into somebody's femur bone and it's soft, you have to take your time and be careful. You take your time and be careful on everybody, but you have to have that thought in your back, hey, maybe I should cement this component. So that's another technique. And so we often will cement in a hip replacement, if you're older, 75 or something like that, history of osteoporosis. So it's always something to think about, for sure.
And you know that before you go in.
Typically, yeah. But I would tell you, yeah. So typically, yes. Age can also cue you in. History of osteoporosis can cue you in, and then you can tell right away when you look at the bone. Actually, look at it physically.
How long does it take for hip replacement, roughly?
Takes me about 35 to 45 minutes to do hip. And knee replacement's 25, 35 minutes.
Fast food surgery.
What's that?
Fast food surgery.
Yeah, it's a huge deal. It's a big deal, but when you do it enough, you get pretty good at it.
So do they do hip replacements without a robot?
Mhm.
And that would probably be longer, I guess.
Yeah, I mean, so I'll tell you, the speed thing is not the number one determinant of stuff for sure. For me, I mean, it's a single ream cup, single stem. So it definitely increases the efficiency because you just know what you're going in to do. You don't have to measure things. You don't have to start small and go bigger. You don't have to do kind of some of those things that we used to kind of historically do.
Are some patients not good candidates for this robotic surgery due to the anatomy of the? This is the way to go.
I think so. So does my striker rep back there. Yes, ma'am. Here we go.
Hi, my
name is Maxine Brown, and I'm 2 weeks out from having my surgery. I saw Dr. Morwood today, and I wanted to let you know what a wonderful surgeon he is. I'm getting my knee at 100% now. After 2 weeks. So don't be afraid.
We gotta make sure Maxine got the lunch with the $100 bill. Thank you, I appreciate it, it's very nice of you.
So your hospital is the only hospital in the area that's doing this? Like, if it doesn't do it?
Biddeford does not, right? Or did they just get one?
I don't know, because I'm supposed to be having mine done in Biddeford.
They do it in surgery, but
Yeah, York Hospital, definitely. And our 2 locations in New Hampshire do as well, but we're doing all, a lot of these at York Hospital.
outpatient.
About 98, 99% of people are just going home same day. It's the only good thing to come out of COVID. Nobody wants to stay in the hospital. And we found that it works. It actually, going home, your own bed, your own food, your own, it's so much better. All right, so we're gonna go to knees. We're gonna go one more case presentation to get it kind of kicked off, kickstart. 50-year-old, long-standing knee pain, range of motion 10 to 110, meaning she can't fully straighten up 10 degrees, okay? And she comes in with her chief complaint. She says, my knee gives away. I never know when it's gonna fail. I never know when it's gonna happen. I'm afraid I'm gonna fall. All right, so here's her knee. And again, you can kind of see it right away. This is the normal knee on the left. Big space there between the bone. That's where the cartilage lives. Can't see on the cartilage on the x-ray, but you know it's there because the bones aren't touching. And over here, we're gone. Worn out completely. And then you can also see that left knee is straight, and that right knee is pointing off towards New Jersey. So that thing's giving out, letting go on her all the time. So robotic assisted knee, straight leg, nice thin part. Without getting too much into the details, a lot of these, what we call valgus knees, used to be traditionally very difficult to do. They're a lot harder than the standard knee. And so people would end up with really, really thick polyethylene plastics because it would be very hard to balance appropriately. And so things would have to get cut all over the place, huge bone cuts, huge soft tissue maneuvers, and you'd end up with like a 16 or 18 millimeter polyethylene insert. This is a 9 millimeter poly because that's just what we're able to do. Again, kind of having that balance, having that intraoperative accuracy and precision. So it's a good one to highlight. And while we're here, we're going to show this in a video. Knee replacement, everybody thinks, oh, you come in, you cut, you throw it out, you put a new, some kind of special cadaver bone or something. This is all a knee replacement is. You make very precise, fine cuts around the bone and then put a cap. Just like a dentist puts a crown on a tooth. All right? Same thing on the tibia. There's just a cap right on the top with a little stem that goes down to stabilize it. You keep your bones, your ligaments, your muscles, your tendons. It's all yours, all your stuff. It's just a resurfacing of that anatomy. So here's, again, healthy bone, arthritic bone. Healthy on the left side of the screen, arthritic on the right. And I'll show you a little bit more of that. This is that x-ray again, not of that other patient, but again, an arthritic knee. Normal cartilage, space between the bones, arthritic cartilage, nothing left. The difference is pretty striking. And this is another big point. For every 1 pound of weight loss, you take 4 to 7 pounds of pressure off the knee. That's because the knee sees so much force when you take that first step. That's why going up and down stairs is really hard. That's why getting from a low position is really hard, because it sees so much stress every time you walk. We're going to see how this video works as well. Sure.
What about the recovery in the knee versus the hip?
A little longer.
With the knee.
So again, here's a knee replacement just generally, all right? Very precise, fine cuts around the bone to fit the cap that goes on. Same thing on that tibia. And then a little polyethylene bearing insert. Your bones, your muscles, ligaments, it's all yours. It's just, again, a resurfacing. Retreading of the tires. Partial knee replacement is also a thing. So when we talk about knee replacements, we talk about compartments of the knee. So there's the inside compartment or the medial compartment, the outside or lateral, and then underneath the kneecap, 3 compartments of the knee. Total knee replacement, we replace or resurface, again, that better term, all 3 compartments of the knee. Partial knee is when you have an isolated issue, whether that's you had a meniscus tear as a kid and that's the only compartment that's worn out, or we've gotten to it soon enough that it hasn't progressed to include the other compartments, then a partial knee can be very beneficial as well. In the end of the day, it's the same sort of idea. It's a cap, it's resurfacing, you're removing that damaged bone grinded against bone, and you're refilling it with metal and plastic. Your bones, your ligaments, your muscles, everything's yours. It's just that resurfacing.
How successful is a partial knee replacement?
So when done for the right indication, isolated unicompartmental disease, it's as successful as a total knee replacement.
And how about the time that helps you get better? Is it a little bit shorter than having a full?
It's a little quicker than a total knee replacement would be.
When you're making, pardon me, when you're making the cuts for actually doing that insertion, is that sort of like CNC, or is the machine determining the cut?
Sure. That's a good one. I'm going to go through all of that stuff in just a couple slides. A lot of people want to know how long this robot been around. You know, am I a guinea pig? Is this first day of the technology? You know, this was done in, I think 2019 is where these stats are from. That was 14 years then. So we're almost coming up to 20 years of robotic assisted joint replacement. Multiple studies been written about it. You know, robots are how many in the country now, Tyler? Over 1,000.
Over 1,000.
Yeah, over 1,000 institutions are using the robot now. And this, again, this 300,000 number, this is way higher nowadays. Maybe 1 million? I feel like Lauren sent out that email a while ago, but regardless, I mean, this is catching on. So there's the big 4, there's Synthes, Zimmer, Biomet, Stryker, Smith & Nephew. Out of the 4 implant companies, Stryker is actually the only one to be gaining market share, and it's 98% to do with this technology as it's more and more adopted. So how does the robotic assistance work for this? This one might have sound.
Let's take a look at how it works. It begins with a
Better voice
CT
than me.
scan of the knee joint. A CT scan is a series of x-rays taken at different angles that can help surgeons see things that they can't typically see with an x-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the Mako system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the Mako system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space, and once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
Everybody always looks that happy in the back here too.
My hair always looks the same.
All right, perfect. So I think that answers some of your questions there that you had, but basically, you know, you get that 3-dimensional scan. We're able to plan those implants, put them right where we want them to go. Remove the bone intraoperatively, again, down to that 0.5 millimeter of accuracy, not taking more or less than we want. Intraoperative, then you get that range of motion. I'm able to see, hey, you can go all the way out straight, you can bend all the way back to 130 or whatnot. the balance medial to lateral, meaning side to side, is exactly balanced where we want it to be. And then we place the implants, and there you go. And so it's just, again, it's a updated way of instrumentation. Kind of in the end of the day, that's all it is. It's an instrumentation method.
So do you have machines that make you move your knee back, up and down, up and down, up and down 1 million times a day?
Yeah, I do not use those. No, they're called CPM, controlled patient, or CPM. Passive motion. Yeah, controlled passive motion. Somebody else. I don't use it.
Thank you.
We used to. Some people still do. There's no studies that show benefit to it, but some people do.
What about the maintenance of the robot? Does it have to be checked?
Yeah,
between-
it's incredible. There's
Who does
check.
that? Is there a technician?
There's
Is it
they got a
just
whole
right there?
they got a whole technician team, a whole team of people kind of
Every
down.
day?
Not every day, but there's routine scheduled maintenance, and then there's maintenance kind of intraoperatively and throughout the day if there's something happening.
We think on the same wavelength. Have you ever had one of these things, the software crash while you're doing it?
Chicago man, Chicago man.
No, not intraoperatively. It's I mean, there's got to I'm not gonna say it's not gonna happen, but it has not happened. Now sometimes the robot either won't boot up, won't start. I mean you gotta troubleshoot. There's troubleshoot teams. There's hey, did you try that? Did you blow on it like a Nintendo game? There's all kinds of things like that. And that's happened where we've had to kind of troubleshoot before the patient is there, but never intraoperatively. If it does happen, onboard computer kind of comes back into it, can finish the operation. In the end of the day, you have to be a surgeon. You got to understand what you're doing, how you're doing it. This is just a technique and an ability to do it more accurately. Still understand the principle. Still understand what the goals are of what you're doing. Yes, sir.
Hi, Dr. Morwood. We're seeing you on Monday.
Yeah.
Best recovery's been slow to say the least. She's at 12 weeks. There's still quite a lot of discomfort. But for the benefit of the audience, could you explain what could go wrong that would delay the anticipated recovery rate?
Yep. Yeah. So everybody, again, like I said, bell curve, right? Everybody's a little different in terms of the speed of the recovery. There's mechanical reasons, and then there's kind of soft tissue reasons. This essentially eliminates mechanical reasons. Now, there can be some outliers for sure, but a lot of issues in terms of healing, delayed healing, rehab is a lot of soft tissue things. Some people make a little bit more scar tissue than others. Some people could be doing the right exercises. Some people could be doing the wrong exercises. Everybody's a little bit different in terms of kind of how stuff proceeds. And then from there, again, you go back to, let's look up the things that could be wrong. Could there be some sort of infection? Could there be some sort of loosening? Could there be some sort of other inflammatory process that's causing some issues? So there's definitely stuff. Right? There's always the art in terms of the experience and the science. So you got to match up the two for sure. Yeah.
What about anticoagulants? Do you routinely put the patients on?
Yeah. So everybody gets something, not pre-op, but everybody gets something. And for me, and kind of the standard of care around the country is aspirin, 81 milligrams twice a day.
Post-op.
Yes. Yep.
What about if the patient is on Eliquis blood thinner prior?
Yeah, so the blood thinner issue is not necessarily worked out, figured out yet. Historically, Coumadin was the medicine, and that was studied quite heavily in terms of kind of can you continue it throughout? When do you restart? What does the INR need to be? When you have medicines that don't have very good monitoring, there's no monitoring for Eliquis or Xarelto, some of these novel anticoagulants. It's a little bit more difficult. A lot of my practice, doing a lot of the traumas, there's situations that I can't control. People are on blood thinners. People need to be on blood thinners. People, so I've kind of adapted and I'm able to do certain things that a lot of other people aren't comfortable with because the more things that you do, the better ability you have to kind of take care of that. So for me, it's not a contraindication. Meaning you can be on blood thinners and you can restart blood thinners and we can get you through safely if that's what you need. But that's there's some unanswered questions with that.
Would you stop them if you knew? If you knew
Well, you gotta be on,
something's
you gotta be on
it?
something, you know, so a lot of times,
Pre-op, I
yeah, pre-op, a lot of times,
Or you just say go off. for
you're either gonna
4
go
days.
off for a little bit beforehand if you're at low risk. If you're at high risk, you can bridge. So you can use like a Lovenox or some low molecular weight heparin.
Right.
Just as a thought process, doesn't this surgery eliminate some of the heavy bleeding because you're not cutting as much?
Great idea. In theory, no, because every surface, you know, even if you take a millimeter or you take 2 centimeters, it's the actual lining of the joint typically that you get the bleeding from, and the bone itself. You know, so even if you just take a little bit.
These caps, how are they attached to your bone, and how long is the knee generally good for?
Yeah. So same as the hip, either a press fit or a cement. In the hip, it's about 90% press fit, 10% cement. In the knee, it's probably 75% cement, 25% press fit.
It's the same lifespan.
Same lifespan because again, it's that polyethylene insert. Yeah.
Can you develop arthritis after a knee replacement?
Nope. So we use the term arthritis. All that means itis is inflammation, and arth is joint. So it's just a catch-all term for inflammation of the joint, whether it's rheumatoid arthritis, osteoarthritis, post-traumatic. That's what it is. When you remove that damaged cartilage and bone and muscle, or not muscle, remove the damaged cartilage and the inflammatory generators, that you are technically removing the itis from the joint. So you're kind of removing all that arthritic chain.
Mine just goes back to the blood clot situation. I hold on to both my knees, but I have 2 prior blood clot situations, not for any specific reason. My primary has said if I ever had replacement, he would put me on blood thinners, but
Yep.
I know that that's one of the highest surgeries that you can develop a blood clot.
Mhm.
So, what have you ever had to do surgery on people that have blood clots or
Mhm.
just had in the past, I guess I should say?
Yeah. So you're right. The nice part about hip and knee replacement is that you're mobile afterwards. So things like in trauma where you can't put weight down or something like that, your wheelchair, those are extremely high risk because the muscular contractions in your extremities is really what gets that blood pumping a lot. Folks who've had either previous blood clots have a very high risk, whether it's a genetic disease like factor V Leiden, something like that. We'll put them on a little bit something higher than aspirin BID.
But my other part of this question I have, I've been looking up like stem cell therapy,
Yeah.
which I know that's all sort of new and coming up and coming, probably eventually it'll be more popular. So that's my fear as far as blood clots go, but then again, I see mixed reviews on stem cell, especially if you have bone on bone knees, any healing.
Yeah, the stem cell therapy will certainly pad your wallet a little bit. It's very difficult to pad the knee. I just came up with that, but I should. No, but seriously, there's no data that says it helps at all, and it's incredibly expensive. Things that can potentially have some anti-inflammatory effect, PRP, that's been shown in studies to provide an anti-inflammatory effect. The idea that you can grow things back with some liquid squirted in is no. I wouldn't recommend it. Yeah. If it doesn't hurt, you go for it. But I would not
I
potentially.
know there's more businesses coming in, but it almost seems like it's money for
It's certainly tricky.
like start a business and you can make the money because it's cash.
Yeah, I'm not up here to disparage anything or anyone, but if you're gonna go to things that have sort of a scientific foundation, whether that's peer-reviewed studies, some sort of idea, that idea is a little bit kind of it makes some sense because you're like, well, I'm gonna take some cells that could grow into anything, I'll put them in there, and we're gonna hope that some local kind of milieu allows it to grow to what I want it to. Kind of makes sense from 1,000 point view, but actually in essence doesn't do anything.
I think it's just because of the blood clot in the past 5
Yeah.
years. You search everything, what
Yeah.
can you do without having that surgery, but
Oh,
in
for sure.
reality, I know.
And like I always tell people, just because we do 8 of these a day, you're one of one, right? So it's a huge deal. It's not something to discount at all. But you know, definitely have things to think about to get you through that sort of thing, and don't let it be a non-starter. That's for sure.
Let's say somebody has two bad knees.
Yeah.
And you're doing a lot of, shuffling. And if you replace one, and then you're gonna do another one at a later time, is there anything that, let's say one person's leg, maybe a tiny bit taller, and the other, is that something that you will identify before surgery? Can you make, I guess, one leg a quarter of an inch taller?
Yeah.
To adjust to the other one? I don't know.
In a knee replacement, typically not, except for this. If your knees are, let's say you're terribly bow-legged, if you straighten one out, see the difference in length now? It's just an angle thing. So some people will, if they have a very bad deformity, you straighten one out, all of a sudden that leg does technically become a little bit longer. So we see that every once in a while.
But by doing a number two, that could be corrected, so they're pretty much.
Match up. We're getting close on time. I want to be respectful of everybody, but this is the slide I think I would end on, honestly, is to say, look, in the end of the day, like I've said, what we're trying to go for is accuracy and precision. Well done joint replacement, regardless of if it's robotic assisted, non-robotic assisted, computer navigated, handheld navigated. There's all these things out there. You want a well done job for the right reasons. And I would never say negative things about any other people or ways to do things. But what I would say is that the current technology that we're using allows for accuracy and precision every time. And so I think it gives us the best opportunity to get the best fit for every individual person. So that's what I think this technology really does. And the only other thing I would point out is that we put together some videos online that kind of has a lot of this stuff parsed out in these little minute videos. We named it because my last name starts with an M. But there are a couple of different, lots of these commonly asked questions. Is there a point where it can't be done? What can I do? How long does it take? On this website, and I think we handed out some of those flyers. So a couple more questions for sure.
Yeah, what's the procedure to get going on having this done? The very first thing, who do you go to talk to about it?
You go to the front check-in desk and get my phone number, and then we bring. You come in for a visit. You get some X-rays, right? Talk to what's your story, how are you feeling, where did how did you start, how long has it been bothering you, what have you done for non-operative treatment, have you tried this, that, and the other thing. And then when you're bone on bone and you've decided, hey, look, time's right for me, then we schedule you up, fix it, find a date, and get it done.
So we start off with a trip to your office to get X-rays and that sort of thing?
Yeah, so the first thing is that consult. You gotta, whether it's a primary care referral or just to call up to the office and say, hey, I've got hip and knee pain, want to be checked out.
Okay, thank you.
Yeah.
What's your thoughts on cortisone shots?
Yeah, so cortisone is probably our number one adjunct.
For him.
Yeah, kind of the number one adjunct in terms of non-operative pain relief, whether, after you've tried medicines. Hips do not work as well as knees for whatever reason, smaller joint space, a little bit different mechanics. They could be helpful. But a lot of times we use hip injections as diagnostics. So the hip has a lot of overlying pathology, meaning you can have pinched nerve in your back, can mimic hip pain. You can have soft tissue irritation, bursitis of it, which is mimicking hip pain. And so if the x-rays maybe are a little unclear, or the position of what you're relaying and your pain is a little unclear, you can pop a cortisone shot in your hip. If it helps, we say it's hip joint. If it gives you zero relief, hey, maybe it's a pinched nerve in your back that's causing some radiating pain around.
What about knee replacement surgery?
Yeah. So knee replacement surgery, right, like we were just talking about, I mean, that's essentially just resurfacing all of those damaged portions of the joint. You're keeping all your ligaments, your bones, your muscles. It's just that resurfacing.
Because I've had both my knees done.
Yeah.
In 2009.
Yeah.
But now I'm having a lot of knee pain again. From,
Oh, revision surgery.
Right.
Yeah.
Okay, revision
Okay.
surgery.
Yeah. So people think I'm really young. I was alive in 2009, so that's the first thing. Second thing is, no, I do see a lot of revision consults, for sure. I'm one of the only people in town who does revision surgery, so I see a lot of hip and knee issues.
Now, is that surgery more difficult than a regular?
Yeah.
It is?
Yep.
Longer rehabilitation?
Sometimes, yeah. Again, for what reason? Is it, if the implant is grossly loose and you pluck it out with your fingers, you're going to feel better in the recovery room. If it's malpositioned and you've got to chip it out and you've got to, crank on this and burr on that and everything, yeah, it can be a little bit longer.
And will you do both knees at once?
Multiple studies have looked at that. We used to maybe do that a little bit more in the historical design. Higher risk of having a complication, blood clot, pneumonia, issues with wounds. It's just not a smart idea.
I did want to say that having had you do my knee,
yeah.
I had no idea. Luckily, my modeling days are over. But some people wonder what your scar is going to look like.
Yeah.
And it is truly amazing. And you use glue, and so people might not realize that there are no stitches involved.
Yep.
And yeah, I mean it's pretty. I've actually shown it to my cardiologist and my PCP, and they're all like pretty darn impressed.
Yeah. I did a third fellowship plastic surgery.
There you go.
It's nice. It's almost like it's like a present. The only thing that people see right is the outside. So you definitely it can be very detrimental to have staples or big suits. So it's nice to hear that.
Do you do iovera injections beforehand?
Yeah, my practice does offer that. So they're currently the only insurance that accepts that is Medicare. So you got to pay out of pocket if you don't have Medicare.
What is that?
It's a ultrasound guided radio frequency sort of cryotherapy. Essentially, what it does is it tries to numb the nerves around your knee. Instead of surgery. Yeah, definitely. So what I'll do is I'll just say thank you to everybody. Anybody else, I'll be here for a little longer. Come on up and ask questions, but want to be respectful of your time. So thanks again for coming.
Thank you.